I would like to introduce Dr. Nancy Kusmaul. She's an associate professor in the baccalaureate social work program at the University of Maryland, Baltimore County. She received her PhD from the University at Buffalo and her master's in social work from the University of Michigan. She was a nursing home social worker for more than a decade. Her research focuses on quality of life and quality of care in nursing homes, organizational culture, trauma-informed care, and the impact of trauma experiences on workers and care recipients. She's co-chair of the NASW Maryland Committee on Aging and a fellow of the Gerontological Society of America. Dr. Kusmaul was a 2019 to 20 Health and Aging Policy Fellow, and she's done several podcasts on aging, trauma, and nursing homes on various platforms. So I hope you can see that she has tremendous expertise to share with us today on trauma-informed care and dementia. Welcome, Dr. Kusmaul.
Thank you. Thank you for having me this evening. We're going to talk about trauma-informed care in dementia tonight. I have my formal learning objectives, but what I really hope to do tonight is give you an overview of commonly used definitions of trauma, an overall sense of trauma-informed care. I want us all to be thinking about special considerations for trauma and trauma histories when somebody has dementia. I want to think about trauma-informed care in the context of age-friendly and how they do marry quite well together in terms of service provision. And I want to leave you at the end with some practical, down-to-earth kinds of things that you can go back to your workplace and do tomorrow. I know it's not quite as late on the West Coast as it is here in Maryland, but I don't know that you're going to go back and do them today. But tomorrow is a good time to start some new changes. So I'm going to start with a couple of polls just to give myself a sense for who is in the room. And so this first poll does have 2 questions in it, just to give me a sense for who you are and what kind of setting you work in. So if you can please answer both questions, I'd appreciate that. I see the social workers are jumping right onto it. So yay the social workers out there. Thank you to those chaplains. Yes, I did not list that as an option. Sorry about that. But I see, yes, social work, nursing, physicians, therapy, nurse practitioner, physician assistant, some caregivers out there, community members in all types of settings. So I'm hoping that I will have something to say to all of you, and there'll be something that you can take back to your work, your approaches from this presentation. All right, well, I'm going to end that poll and move on. So let's start with some definitions. So again, more participation. I want to get a sense for what you think trauma is. And I think that is this question here. Yes. So what is trauma? Or what definition of trauma do you use most commonly in your life or your work? what the patient sees as trauma. Yeah, that's really important. And we will definitely get to that, Mary. All right, give you like 10 more seconds. All right, there we go. So as you can see, most people chose an event, series of events, or set of circumstances that the person experiences as traumatic. And as far as the literature and the practice community go, both of these answers are used. Both exposure to death, threatened death, actual or threatened serious injury, actual or threatened sexual violence through direct exposure, witnessing in person, indirectly learning of a loved one's exposure to trauma, or through repeated occupational exposure, and an event, series of events, set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effect on the individual's functioning and mental, physical, social, emotional, and spiritual well-being, are both definitions that are used in different parts of the practice world, maybe for slightly different purposes, but the perspective matters. And it's important to understand what definition of trauma your profession operates from and what definition of trauma your workplace operates from, because there are some nuances in how you might approach trauma and trauma-informed care, depending on which of these definitions you're operating from. You know, potential trauma is universal. Some people look at something like trauma-informed care and say, well, that's just life. And it's true. We all have the potential to experience something traumatic at any point in time. In our sort of big three, the CDC, the American Psychiatric Association, and SAMHSA are really where we draw some of these big definitions from. Centers for Disease Control focuses on adverse childhood experiences. The APA defines trauma primarily. DSM-4 and 5 have some slight differences, but mostly in the context of trauma-related mental disorders, so PTSD, for example, but not only. And SAMHSA looks at it from more of a functional perspective, applying trauma-informed care for adults, mostly in behavioral health services, but we're definitely seeing expansion of that across different types of service settings. Adverse childhood experiences are those potentially traumatic events that occur between the ages of 0 and 17. Very much based on a population study done in the late 90s that looked at experiences of trauma in an adult population that used general medical services. But those categories that we think about in terms of adverse childhood experiences are all types of abuse and neglect that again occurs in childhood, witnessing violence in either domestic violence or other types of violence in either the home or in the community, a broad menu of household instability, and any type of parental separation. So including divorce, including deployments, including really any situation where a child is separated from a parent during that childhood period. The research on ACEs talks about the ways that ACEs can affect health and mortality, even in the absence of changing health behaviors. So anybody who's experienced that bottom, anybody who's experienced an adverse childhood experience, some people experience disrupted neurodevelopment, some people experience social, emotional, and cognitive impairment, some people adopt poor health risk behaviors, or poor health behaviors, but anybody who experiences an adverse childhood experience can have an effect on health and mortality. Accumulating ACEs, so the more ACEs you have, the more that it can impact your body and your health directly. But those unhealthy behaviors make it worse. But since we're thinking about adults and likely older adults, adverse childhood experiences are probably only part of the story. If we focus solely on those ACEs, then we're missing a whole lot of trauma that may have happened in a very large period of life. So military trauma, domestic violence, medical trauma, and I will get into that, but there's a lot of PTSD and other types of trauma as a result of ICU stays, of different types of medical diagnoses. And so thinking about the trauma that some people experience as a result of either serious health conditions and or their encounters with the healthcare system. Also on this list are isolation and neglect and natural and human caused disasters. And I have those bolded because they can occur at any point in the life course. When they're experienced in childhood, they sort of fall into that ACEs category, but we can't forget about them in adulthood as well. Different populations experience natural and human caused disasters differently, and older adults almost universally experience worse outcomes in natural disasters and wars and other types of human caused disasters. It's more challenging for them to evacuate. When they evacuate, they have more ill effects from community disruption and things like that. The APA definition, so again, that uses that definition of trauma in the context of a diagnosis. And it's this exposure to death, threatened death, actual serious injury, or actual or threatened sexual violence. What I like about this definition is that it has an array of ways that somebody might experience that. It can be that direct experience, but it also takes into consideration events that people witnessed directly, events that people learned about. So if something happened to someone close to them that didn't witness it, but that person told them about it, and because of their close relationship, they were adversely affected by that traumatic experience. And this also incorporates those repeated indirect exposure in a professional setting. So if you're in a space where you're hearing these stories repeatedly, it is also included in this definition, and it also is important to think about the ways that we carry these experiences as a result of our work. The SAMHSA definition is in some way the broadest and the most inclusive, and I like it for those reasons. There's no diagnosis required for something to be considered trauma, and it takes into account a person's experience of the event and also thinks about events over time. We know that sometimes a trauma is a one-time thing. Some big crisis, tragedy happened. It's a one-time thing in the context of a supportive environment and other types of good things that happen. We know that for other folks, traumatic experiences are things that happen over time in unpredictable ways, or are the context or a set of circumstances that persist. And they have lasting adverse effects on a broad range of categories. So it's not just mental, it's not just physical, it's not just social, emotional, or spiritual. It can be any or all of those things, and sometimes in combination. So from that, I'd love if you could throw into the chat which definition your practice uses. Is it the adverse childhood experiences framework, the APA definition, the SAMHSA definition, or something else? Or do you not really have a definition, just maybe a set of assumptions? APA, all of them, okay. Parts of all, okay. For those who are saying all, does it depend on the context or the patient, or is it all across different parts of your practice? Not sure. Okay. Depends on the patient. Okay. So an additional part of the SAMHSA framework that I'd like to talk about is the event, experience, and effect framework. And this is really key to SAMHSA's definition because it incorporates individual variability. Uh, It, it really is person-centered at the heart of it, and it accepts that not everybody is going to experience the same traumatic event in the same way. The event is what actually happened. Um, and so this is why I use the word potentially. Just because something can be labeled a trauma doesn't mean that each individual person experiences it as that. And so the event is simply the historical piece, what happened. And it may be, again, it may be a one-time thing, or it may recur over and over again. Too many times we stop here. We often think knowing what happened tells us the whole story. If we say someone's a veteran, if we say someone experienced child abuse, then we think we know the whole story, or we think we know how to treat them. And the great part about this framework is that it doesn't stop there. Okay, great. We know that something happened. We might know what it is, we might not know what it is, but we know there was an event. How did the person experience it? The individual, how they made meaning of it, how they experienced it in the moment, determine whether it was a traumatic event. We see this a lot when we think about any particular event that may be experienced differently by different people. You know, two children that come out of the same household, two veterans that come out of the same military unit that had the same thing happen to them. One refugee may experience fleeing one's country differently from another refugee. How the individual labels and assigns meaning to, and how they're disrupted by an event determines whether it is traumatic. And what are the effects? For something to be defined as trauma, there need to be some kind of long-lasting adverse effects. And the adverse effects might not be immediately apparent. They may have a delayed onset. They may be long-term. They may be short-term. The person might not recognize that the effects are related to the trauma. But some of these effects can include how somebody copes with normal stressors, how somebody develops trust or benefits from relationships, how somebody experiences things like memory and attention. One of the effects of trauma is that you can get hyper-focused on the perceived threat, but that makes it really hard to observe and interpret other stimuli. And so how somebody experiences the world and stimuli, particularly when they feel like something's threatening, can be an adverse effect from trauma that they might not even realize is an adverse effect from trauma. So from this first part, the big takeaways are that not everyone who experiences a potentially traumatic event has a negative effect. Negative effects can be seen long after the trauma. And I will get into some of the reasons for this, particularly with our older adults and particularly with dementia. And two people can experience the same event and have different outcomes. We know this with other things. We just don't always think about it with trauma. The bigger question, and the one that there's not a ton of research on, we don't know a lot about, is how does this change when somebody experiences dementia? You know, what happens when they can't remember anymore? What happens when their coping skills change as a result of their development of dementia? Or when they begin re-experiencing the traumatic event as their memory changes. I know that with other things, sometimes we see somebody almost working backwards in the experience of their dementia. But what happens when there's a trauma in there? And what happens when they hit that trauma along the way as their memory declines? We don't have a ton of information on this, but this is a really important practice consideration because it certainly affects how somebody feels, how somebody is distressed, and maybe even how they experience the healthcare settings. So let's look at some issues that specifically relate to older adults. So putting the dementia aside for a minute. Trauma exposure accumulates with age. So this is one study back from 2014 that looked at mostly white, mostly college-educated folks. So in terms of risk factors for trauma, education, race, and ethnicity certainly affect risk. And yet in this group, they still had more than 6 potentially traumatic events across their life course. The older you are, the more you've been around, the more likely you are to experience a traumatic event as happenstance. And also as somebody increases in age, the more likely they are to experience something like the death of a spouse or the death of a child over time. So put somebody at risk for adverse effects. The developmental stages of later life are also associated with trauma symptoms. So life review is a normal developmental task in aging, but it can cause trauma survivors to relive difficult experiences or to make them avoid that life review part of development because they know there's something back there that they don't want to deal with or have trouble dealing with because it was such a traumatic event. It can also result in reactivation of old trauma symptoms. Even if somebody had developed coping mechanisms, it may cause them to come back up. And somebody can also experience new trauma symptoms from a long ago event. When we think about those experiences that older adults may have happen, grief is not always traumatic. Complicated grief usually is. But grief could trigger a trauma response. The other thing to consider is as older adults experience some of the losses that often come with late life, they don't have to, but they often do, established coping mechanisms may be compromised. So if we think about somebody who moves into a care setting, maybe they were coping with their trauma at home. Maybe part of that coping was control over their own environment or setting up their room in such a way where they could see perceived threats or, knowing in a very predictable way what was going to happen then. Moving into a nursing home or other senior housing often means loss of control over the environment, which could be traumatic or it could reactivate that previous trauma, which had been under control when somebody was in their own setting. There's also the potential loss of social supports, home, neighborhood, community, religious community, significant others, friends, due to death, due to separation, due to changes in care needs of themselves or of those other people, and how that social support network affects somebody's ability to cope. Our current cohort of older adults also have some generational risks. So we're still seeing attitudes and upbringings that may have resulted in people not dealing with past traumas, people who were told to take it like a man or not deal with feelings, or women who were in domestic violence relationships who were told to, you made your bed, just lie in it, that you have to stick with this relationship because it's your spouse. Now maybe aging and developing symptoms related to those traumas. In addition, when we think about dementia, let's think about some of those potentially traumatic events. They may be those deep, dark family secrets, especially things like childhood sexual abuse. Uh, Adult children may be unaware. And so when you're looking to family members to give you some clues about what might be happening for somebody with dementia, they truly may not know. And so we have to consider past trauma as sort of that black box because we don't know what we don't know. The other things that we don't know is really very much about trauma and dementia. It is a small but growing field at the moment. But we don't know, again, how people might re-experience traumas as their cognitive impairment advances. And there's also less ability to engage in evidence-based treatment. So older adults can still benefit from trauma treatment if that's something they want, if that's something they have the capacity to do. But people with dementia really can't. EMDR is one treatment that has been shown to have positive effects in older adults, but you do need to be at least somewhat cognitively intact to engage in that therapy. Since we're pretty much all in medical settings, I do want to talk a little bit about trauma and patient care. Patients with trauma histories are more likely to present with somatic complaints rather than complain about mood disorders, or they don't describe what we might consider to be those classic symptoms of trauma. Many of you are aware that there are increased reports of chronic pain in people with PTSD. And this is thought to be in part due to the fact that patients with PTSD may be more sensitized to pain and be more prone to interpret it in a negative fashion because of that hyperarousal piece. Pain, if it's related to the traumatic event itself, like from an accident, can also trigger the trauma response because of the somatic effects of that trauma experience. People with trauma histories may have also histories of substance abuse, which may make them less sensitive to pain medications like opioids, and so dealing with pain can be complicated. There's also challenges around sleep and mood disorders, or poor sleep related to mood disorders, which then exacerbates things like pain symptoms. So how might trauma look if we don't know what we don't know, if the adult children don't know, if the person with dementia might be a poor historian? These are some warning signs that might trigger us to take a second look. People who are estranged from their family. Now, it's not always related to trauma, but it's often a clue that there might be some hidden challenge in there. An older person might have guilt related to the original trauma, especially if they feel like they coulda, woulda, shoulda prevented it. They may have worse symptoms during transitions. So transitions are hard for all of us. Change is hard for all of us, but people with trauma histories, particularly older adults with trauma histories, may have what we perceive to be outsized reactions or no reaction at all. And there's very little middle ground there. And the research does suggest that people with trauma histories do have a greater likelihood of developing dementia. And once they do, they have greater distress. When we think about behaviors in dementia, if we think behaviors in dementia are communication, then we need to consider always whether a behavior is communicating a past trauma. All right, so I have one more poll here. Sorry. Here we go. So when you're assessing for trauma, what do you need to know? Okay, so some of this will depend on your setting, but yes, okay, let me see. All right, I'm going to give you 5 more seconds. Okay. Pretty much evenly split between that something distresses the patient and triggers uncomforts. And some of that will depend on your context. Sometimes it's enough to know that the patient is experiencing distress, but usually you want to know that not only are they experiencing distress, but what it is that eases that distress. It is a common perception in trauma assessment that you need to know exactly what the traumatic event was, how long ago it was, all of those kinds of pieces. And the short answer is that in trauma-informed care, that's less important. Knowing the symptoms, knowing the triggers is more important than knowing what the actual event was. Stop sharing. Okay. Now, if you are providing trauma treatment, then you may need to know more about the specific traumatic event. But you don't need to know what happened to treat symptoms and distress. You can ask, you can be open about it. Don't react negatively to this disclosures, but disclosure is not necessary to address the distress. Also want to talk about that growth mindset. There is certainly ageism out there in the world. I would doubt that there's less of it in this room, but older adults can respond to trauma treatment and they can choose to treat their trauma symptoms. But trauma treatment and trauma-informed care are not the same thing. And trauma treatment is something that somebody has to opt into, whereas trauma-informed care can be provided to everyone. Symptoms that we may not recognize immediately as trauma include suspicion, lack of trust, anxiety, nightmares, and what does the historical context look like? Not all substance use is a result of trauma, but there is a strong co-occurrence there. So if there is a history of substance abuse, thinking about the possibility that there's a trauma associated with that. History of homelessness, and again, those estrangements or disrupted relationships. And remember that traumatic reactions are functional. Traumatic reactions developed as normal reactions to abnormal situations. And often when a person is reminded of the situation or reminded of how they felt in the situation, so it could be a smell, a noise, something that reminds them of the situation, they will have the same reaction. When you think about patients with dementia and trauma, you want to consider approaches to reduce distress. I mean, this is often our first strategy with dementia in general: reducing stimuli, avoiding startling approaches, communicating touch, think broadly about touch and its potential for triggering trauma survivors, especially those who can't communicate the past events, and being really careful about the way we use touch, positive and negative. There are some people for whom a hug or touch can be comforting, even trauma survivors. There's some trauma survivors for whom that is a significant trigger. And as we think about treatment and care and personal care, it's really important to pay attention to the way that particularly someone with dementia who can't verbally tell us is experiencing touch. You know, remember, obviously, don't take it personally. Don't think you can fix everything. You can have the best approach in the world and somebody may still have a strong reaction. And it may be different from day to day. But always ask yourself, could this be due to trauma? But also realize that the person might not even realize that it's related to a trauma, and assess, address, and change your behavior. The trauma-informed care paradigm has 6 principles: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. Now, in the model, they are treated the same, but they do function somewhat differently. That cultural, historical, and gender issues piece is the lens through which we have to look at the rest of them. We have to consider how culture, how history, how gender may have affected somebody's experience of traumatic events across the life course. We did the land acknowledgement at the beginning, so thinking about the way that Native populations have been treated over history, how the older adults that we're working with may have experienced care systems related to their Native identities, again, across history, gender in the same context. At the other end, safety. I don't want to say that safety is more important than the others, but you almost need to have safety to be able to access the others. You know, we can't heal when we're in survival mode. Much like, you know, Maslow's hierarchy of needs, until safety is addressed, we can't think about the rest of it. And we have to think about what our healthcare settings look like. Healthcare settings may feel unsafe, particularly to people who can't understand the stimuli. They're loud, they're chaotic. Patients who have significant diagnoses, so reoccurrence of cancer, patients who've been intubated, patients who've been resuscitated, have high levels of PTSD and other types of trauma symptoms related to their ICU stays and such. And so when we think about a person's entry into the healthcare system, we have to consider those things. And we have to consider the whole environment. That's where that age-friendly paradigm comes in. So Barb mentioned this at the beginning of the presentation. What matters: medication, mentation, and mobility. So once the safety is addressed, consider the age-friendly paradigm as part of person-centeredness. And the goals of age-friendly fit very nicely with the goals of trauma-informed care. It aims to follow a set of essential evidence-based practices. It is emphasizing causing no harm, and it aligns care with what matters to the older adults and their caregivers. So what does that intersection look like? Well, as we think about what matters, we have to think about safety and trustworthiness and transparency and collaboration and empowerment, voice and choice. So how do we fit those trauma-informed care principles into how we assess what matters? When we're assessing what matters, let's talking about trustworthiness and transparency, for example. somebody is not going to share what truly matters to them unless they feel like they can trust. And so thinking about how we're establishing trust with patients is important when we think about age-friendly and we think about trauma-informed care. When we think about medication, is someone with a trauma history using medication to mask trauma-related distress? Or the flip side of that, that as they can no longer participate in active treatment, they might need a medication for distress? And do we each have cultural or gender biases that influence prescribing? Just throwing in here a resource for you to use if you have, when you have access to the handout, you'll have access to this link. There's tons of hidden bias tests. Consider taking one. Consider understanding for yourself what your biases might be, because that can influence prescribing, and it can certainly influence how you're assessing for and thinking about traumatic experiences in different communities. The mentation piece of age-friendly, going back to what I said earlier, that trauma increases the likelihood that somebody has developed dementia, and they often have greater distress in dementia than somebody who doesn't have a trauma history. And as we think about mentation, particularly in the acute care setting, how does this distress play out when somebody has delirium, and that interplay of dementia, delirium, and now trauma symptoms, and how that might play together, and what our reaction to that might be as providers. When we think about mobility, we often get caught in this safety loop. Um, we want somebody to be able to move around, but at the same time that they're not safe to move on their own. And so we try to restrict their movement so that they are safer. But how does that affect somebody's emotional safety? And does it feel safe to you if somebody's telling you, oh, don't get up, or wait for me, and yet people don't come to help you to the bathroom or something like that? And so when we think about safety and mobility, are we thinking about both the physical and the emotional side of that? And do patients trust that somebody will come when they need them if they can't get up on their own, or if we don't want them to get up on their own? If we apply these principles well, trauma-informed care, if we apply age-friendly, we'll have better patient safety because they will trust that we will be there when they need them. We'll improve the outcomes that are important to them. We will reduce everybody's distress. Often relieving the patient's distress is the first step in relieving the distress of family members and relieving the distress of staff. And if we can approach it from that perspective, it's better for everyone, and that better communication between all the parties. So I have a couple of case examples in here. And I've got some questions built in, and I'd love for people to answer in the chat, ask any questions that they have, because I want to think about ways that we can make these encounters. They each describe a care encounter, and I want us to think about ways that we can make this care encounter trauma-informed and age-friendly. So in this one, Sam arrived in the emergency room from his long-term care community due to a fall with a suspected hip fracture. He's got some mild cognitive impairment, and his daughter is his primary decision maker. She's been called and she's on her way in from a meeting in a nearby suburb. So patient gets there, daughter's still about 20 minutes out. So as you start to assess Sam, which of the 4 M's should you focus on first? What matters? Okay. Mentation, what matters? Okay. Okay. So I'm seeing what matters in mentation as the primary answers. Um, so how do we assess what matters in a patient with mild cognitive impairment whose daughter's still on the way in? Is that can we assess that in the patient? And what can we assess? Pain, okay. History, okay. Depends on his ability in that moment, okay. Good. I think it's important that we think about how we build the 4Ms into the practice flow. I mean, we are very much moving towards a practice environment of care paths and the checklists in the EHR and what it is that we're doing in what order. So I think it's important that we make sure that 4Ms are built into those mechanisms if that's how we're practicing. Do we have a what matters flow sheet? Do we have those things that we can address with him right now as he comes through the door, and those things that we focus on with family when the family comes in? Are we using evidence-based practices like the Beers criteria, the American Geriatric Society list of potentially inappropriate medication use in older adults? Are we assessing for delirium? Are we prioritizing mobility? And how can we do that when we have to address pain and we have to assess for, in this case, a hip fracture? When we think about trauma-informed care, we have to think about what principles are universal, what we're doing for everybody, what's more targeted, and then where that clinical treatment would be appropriate. For everyone, we should be providing support. For everyone, we should be providing information. We should be screening. We should be screening for strengths. And if we're not, and again, what do you need to know? We should be looking for documentation from the nursing home on distress. We should be looking for documentation on, I'm going to air quote it because I hate the term, behaviors. What are we learning from his history to help relieve his distress now? Distress beyond the I fell and my hip hurts. Distress from the new setting, distress from the triggers and the stimuli of an emergency room environment. If he has distress, what additional supports can we provide him in that emergency room setting? Extra support, monitoring, and extra support, not just putting a one-on-one on him to make sure he stays safe, but actually supporting him and referring him for mental health treatment if it's appropriate. If it's appropriate based on his cognitive status, if it's appropriate based on his symptoms. Yes, Elizabeth says she uses the word distress instead of behaviors, and I think that's a really important reframe. Barb, I see we have somebody with a hand raised. Do you usually just ask them to put their concern in the chat?
Yes, if
Or the
Lisa, if that would
question?
be possible.
Okay. So Lisa, I see your hand there. Thank you. If you can just put your question in the chat or in the Q&A, we'll get to your question. So when we think about trauma-informed and age-friendly, I know there's a lot of words on this page, but thinking about, from a trauma-informed perspective, addressing distress, pain, fear, grief, distress, minimize potentially traumatic aspects of care. So in that emergency room setting, thinking about touch and startle and how somebody who doesn't understand is experiencing something like an X-ray or an MRI. Reassurance. the realistic medical information, or not talking around somebody with dementia, but providing information on a level that they can understand. Providing emotional support to the family, helping the family provide emotional support to the patient. But being aware of potential for family conflict. We very much have a default of calling in the family, and yet that's not always the best option. So we should be aware when we think about what matters is who it is that the patient wants to be involved in their care. So as Sam's daughter gets to the emergency room, what have you already done for him? And what's next? X-rays of pain management. Okay. That seems like a good first step to me. But have you done, so the pain management addresses perhaps his distress. Is there anything you've done specifically to evaluate his distress? Excellent. Establishing where he is cognitively, what he understands, and finding out what makes him comfortable and safe. Yes. Talking to him, not just checking off that he's got dementia. Let's move on. Making sure that we're including him and even just reassuring him as you assess him for his cognitive understanding of what's going on. And making sure that, exactly, Wendy, explaining things that are being done. It seems like more work. It seems like more time. We're all rushed. We're all hurrying. And yet, in the long run, it'll take less time. In the long run, providing that reassurance, providing that trauma-informed approach will result in better outcomes for everyone. So in the nursing home, and I saw this a lot in my nursing home practice, somebody started out on rehab. They were going to go home and it didn't work out, and they stayed for long-term care, and they were moved to another part of the building. And you didn't always get a ton of report from the staff on the rehab unit. You learn from her record that she's widowed, she has 3 children, she's only in contact with one because who lives out of state, and the nurses in rehab said she's anxious and irritable. And so for me, with the trauma-informed lens, is I want to know more, if possible. What's up with the other kids? Why are they not in the picture? And again, in a non-blaming, threatening way, but just trying to understand the whole picture, but knowing I might not get the whole picture. Trying to understand what she's anxious about. You're not going to be always going to be able to address every aspect of anxiety, but what it is that she's anxious about. And thinking about how a lot of times for people with anxiety, that trustworthiness piece is a challenge. And it's why it's so important to not overpromise, but to say what you'll do and do what you'll say, and how you as a individual provider can live up to what you tell the patient you're going to do, and how you collectively, your care setting, can make systems easier for people to be able to do what they're going to say what they'll do and do what they say. Thinking about those trauma-informed care and age-friendly principles as we work with patients. Addressing the symptoms without being aware of the underlying trauma. Assessment is a part of the package, but it is not the whole answer. So for those of you in nursing home settings, in the nursing home revision, policy revisions, and they added trauma-informed care as phase 3 of the nursing home regulations. When the guidance came out from CMS, it very much focused on assessment. And so there are nursing homes out there that believe, okay, well, we put a trauma assessment into our admissions packet, box checked, we're done. And it is so much more than assessment. It is so much more than, an assessment alone is definitely not the answer, because you don't always know, you're not always going to learn what happened, and you don't have to relieve the stress. What you do need to understand are the symptoms or those pinch points of distress. A truly trauma-informed environment assumes that everybody might have had some past trauma: staff, family members, clients, residents, patients, and looks at all of the processes, all of the environmental features to think about what that looks like. In some work that I did in a refugee space, for example, the same practices that made one person feel safe made another person feel less safe. And that's the challenge with trauma-informed care. In this setting, the refugee shelter was in a not so great neighborhood. And so they had a curfew and a locked door policy. And there were some people for whom knowing that door was locked made them feel safe. And for other people, they felt trapped and threatened because of that locked door. There's never going to be a perfect organizational approach, but it is important, as you think about putting organizational practices into play, that you think about the different ways that people may be affected by the same practice. But trauma-informed care can be provided in any setting, anywhere. You can provide trauma-informed care in the shoe store, but thinking about all of those different policies and practices and the way that they may affect different people and what those unintended consequences might be. So what does it mean to provide care that promotes safety? How physically safe do people feel? So not just how physically safe are they, but how physically safe do they feel? Is emotional safety sacrificed to enhance physical safety? So in my nursing home work, how many times did we tell somebody, no, don't get up, don't get up, don't get up, because we're worried about you falling? But then they felt really trapped by that. These were in the days when we used alarms, and the alarm would go off every time they got up. In the research, physical safety was enhanced by specific actions, where emotional safety was enhanced by attitudes and approaches. So emotional safety was about making people feel safe, whereas physical safety was about doing particular things, answering that call light, getting them to the bathroom when they needed it, all of those kinds of things. The way that staff responded to incidents made people feel safer. Trustworthiness includes, again, delivery of services as promised, openness, and follow through. Are you personally, or your organization, open to new ways of doing things? Do you promise things that you or the setting cannot deliver? It's one thing to reassure people that this thing can happen. It's another thing to actually make sure it happens. If you're personally not the right person to follow up on a particular thing, do you follow up? Do you get back to somebody if they bring a concern to you, do you get back to them? That's part of trustworthiness and transparency. Peer support. Are there places and opportunities for patients and staff to interact with others with similar interests and experiences? Can staff interact with other staff at a similar level in an open and honest way? Or are there cliques or their fears about communication between supervisors and providers? Everybody should be able to feel safe, including the staff. What is the collaboration like? Is there a sense of a common goal? Is there a sense that we're all out to provide the same care? And do the residents believe that, or the residents, patients, do they believe that you're all on the same page? And if not, why not? And empowerment, voice, and choice. Who has real control? It's hard for us as providers to provide a sense of control to our patients when we don't feel like we have control over our practice environments. Acknowledging right up front that, the insurance companies, the executive team, whoever it is that dropped that new EHR in, that you just have to do it this way now, without feeling like you have a voice. So how do you promote choice for patients when your own choices are limited by the system? These are questions, not answers. And I'm hoping, I'm thinking you probably were hoping that I'd give you some answers. And it's a yes and. Our practice realities are tough. We systems could do a lot better than we do, but we individual providers could do a lot better too. And so there are things that we individually can control, even in the context of an environment that is restrictive. And how do past issues, our own past, the past that our patients have experienced, shape current perceptions? How does it shape their trust? I'm in Baltimore. Henrietta Lacks looms quite large and the Johns Hopkins legacy looms quite large in some populations in Baltimore. And how do we address that? If you're in a Native community, how do you address things like residential schools and other types of abuses that occurred by systems that may still exist? And thinking about how that affects perceptions of safety, perceptions of trustworthiness in different populations and different contexts. Why those principles? Trauma is typically about experiences that occur beyond an individual's control. Trauma-informed care, as much as possible, tries to restore control to the individual and reduce control by the system. And how do we take this? Organizational culture, I love this definition because it's the shared norms and attitudes that shape collective behaviors. Or as we know, the way we do things around here. What we would hope is that policies and practices line up. We know that's not always the case. I think about some of the nursing homes I worked in where the new CNAs would get this great orientation about all these wonderful things that we do, and then they'd get up to the floor and their preceptor on the first day would say, oh yeah, they say that, but no, we really just do this other thing over here. You really want to so your policies and your practices to line up as close as possible. And trauma-informed care requires us often to change both culture and practice, culture and policy. Changing the policy is not enough if we don't also change the culture and the practices. But it doesn't require a complete organizational shift. I'm sure that in every one of your organizations that you're doing something right now that is trauma-informed. And so, you know, if you have something you want to throw in the chat that you feel like your organization is doing really well, they're out there. And that is the low-hanging fruit. That is the stuff that you can build on. But taking a good look around and figuring out what it is that you're doing well is the first step on the journey to trauma-informed care. As we think about trauma-informed care, we can apply them again on that individual, that organizational level. But you as a practitioner, as an individual, have the power to make your practice more trauma-informed a little bit every day. Trauma-informed care is not a destination. I will never, give you the gold medal for trauma-informed care. It is about each one of us doing better today than we did yesterday. And being cognizant of staff dynamics. As I mentioned, all those pieces in our organizations, the insurance and the very big structures and the policies, they can feel like constant threats to the organization. And the more threatened the organization is, the more that staff dynamics can mirror those abusive situations. And staff that don't feel safe in that environment cannot have more trouble being present for resident trauma. And we know this in so many other ways. We know this when we're not wearing our trauma-informed care hats, that we have to take care of staff to be able to for them to be able to take good care of residents. And so being cognizant of how we're feeling about our workplace, but being cognizant of how other staff and other parts of the organization might be feeling as well. If I'm the administrator, I might feel great. I have lots of control. I can decide what my schedule is. I can feel like I can say whatever I need to say. But does everybody feel that way through the organization? Probably not. And so being cognizant of how different people in different places in the organization may be feeling about it. When we think about the trauma, we have to realize the widespread impacts of trauma. We have to recognize the signs and symptoms that may be present in ourselves, our clients, families, staff, and others in the system. We have to respond collectively and individually by integrating trauma into policies, procedures, practices. And by doing that, we will actively resist re-traumatization. What organizational practices could change with minor tweaks? Look for the low-hanging fruit. Are there small physical changes that would increase safety? And here's what you can do. Here are the 3 things that you could go and do tomorrow. You can walk around your facility or your practice setting using all of your senses. Look, listen, hear, noting lighting, security, privacy, and make yourself a list of things that need to be addressed. Are they small things? Are they things that need repairs? Is it a light bulb that's been out for a month? If those are the kinds of things, put in a work order. You can do that. But bring those larger items back to the team. What's not working? Are there spaces where patients don't have privacy when they're getting care? What do you see? What do you hear? What do other people see and hear? And how can we address those things to enhance safety? Trustworthiness and transparency takes time to build, but you can start by changing your own actions. We are have been in times of fear and uncertainty in healthcare long before COVID even came around, and it's only been worse since then. But in those times, it's even more important that you individually be as clear and as transparent as you can with patients, families, staff, coworkers, because all it takes is one. We know that the opposite is true. When one coworker is being negative, it can bring the whole show down. So all it takes is one person who is operating from this frame to build trust and rapport, to start to build trust and rebuild trust and rapport among your work group. And take time to take care of yourself. Seek support from your peers, especially during difficult times. That's when it's easy to do away with the huddle. We're in a hurry. We can't have a huddle today. But those times when people can come together and support each other, especially staff in similar positions. Remember, when it comes to trauma-informed care, it is not trauma treatment. Trauma-informed care doesn't mean that all staff has to provide trauma treatment. All staff shouldn't. All staff is not qualified to provide trauma treatment. But we all can be aware of trauma. We all can incorporate trauma-informed practices into our individual and collective approaches to patients. Got some references in there, which you'll have in your slide deck that's available on the website, as well as my email address. I'm happy to address questions now, but if you think of something afterwards, please feel free to reach out to me via email. I'll leave that up there for a minute. And then if we have questions in the Q&A, Barb, I'm happy to address those at this point. I've been following the chat.
Yeah, you've been doing a great job of following the chat. I actually had a question because I thought it was interesting, the people from different disciplines that are on the webinar, and I'm wondering if you have some additional thoughts about various roles based on, you know, their positions or disciplines in caring for older adults. To what extent people can safely tackle issues of trauma-informed care, or should refer. I don't know if you get a sense of what I'm asking here, but
I think I do. So I'm going to try to take a stab at it, and you can tell me if I'm completely off base. So trauma treatment should be handled by a mental health professional. There should be a referral to a psychologist, a psychiatrist, a clinical social worker, whoever does the mental health treatment in your setting or in your community. Unless you are specifically trained in that, you should not try to do trauma treatment. All of us can provide trauma-informed care, from the CNA to the administrator and everybody in between in any kind of setting. So how can any member of the team think about ways to increase collaboration, can think about ways to increase trustworthiness, to think about safety, and not just patient safety. Patient safety, yes, should be utmost, but if the patient care tech doesn't feel safe enough to report when they make a mistake because they're afraid there's going to be retribution, then maybe they won't fix that and then make somebody else unsafe. So all of us can practice in ways that make everybody safer, for example, or more trustworthy. Like that's on all of us. The trauma specific treatment should be provided by the mental health professional. Does that help?
that does help. Thank you. I was also thinking, we have had in the past folks from APS on the webinar. Do you have a sense, because I'm thinking of trauma, of a role vis-a-vis APS in trauma-informed care?
I think it's important for any body or any group who knowingly encounters trauma on a regular basis to think about trauma-informed approaches. And a lot of what APS already does is sort of harm reduction kind of model. If they can't get completely fix the situation. And so you think about that in that way. They also have to think about supporting themselves as they are continually exposed to trauma, and how they can do that through peer support and other types of collaboration. So yeah, those trauma-informed principles, but applying them to themselves and their work as a whole.
That's helpful. And Jessica, I've just given you speaking rights as much as webinar will allow me to. If you want to pose your question, I see your hand is up.
Okay, can you hear me okay?
Yeah.
Yes.
Okay, great. No, I just wanted to add for trauma-informed care, because I used to be in behavioral health. I was working on our PTSD clinical team, and then I recently just switched over to our non-institutional care department. So I'm kind of getting like both, you know, and it's very helpful. Like with trauma-informed care, I just want to clarify, just to be able to ask the appropriate questions, just to be able to acknowledge what is there, just to know, you know, what is going on with the patient, and if it's something that, you know, it's maybe related. I think more trauma-informed care is about acknowledging the trauma behind their, you know, their history. And like you mentioned, you know, the mental health professional to deal with the trauma.
Mm-hmm.
I think with this is really great, because there's not really a lot of collaboration between primary care and behavioral health at my facility. We're trying to get better at it. They put things in place to try to grow from that. But I think just basically for trauma-informed care is just to acknowledge that it's there. And then for the actual trauma therapy or trauma, you know, anything like for behavioral health wise, just to know when you need to when do you need to inform somebody that they, you know, maybe they would benefit from behavioral health therapy.
Right.
So all of it, you know, it's growing into like little pieces, like puzzle pieces, just, you know, coming together.
Mm-hmm. Absolutely. Thank you.
Thanks. Any other questions? I think you've done a nice job of addressing people's questions as it goes along. Oh, I see Sheila has a question.
So what I'm assuming that's measures, can caregivers use in a fight or flight? It depends how the symptoms are appearing. It depends on what it is you're trying to do with a patient. You know, I would say the first step would be to stop what it is you're trying to do. Take a step back and seeing what it is that's causing them distress, and then reapproach and take it slow and take it one step at a time, and explain what it is you're doing one step at a time. And yes, it takes time, and that's a problem in the way our healthcare system is set up, and I acknowledge that. But the more time you can take, and if the patient is open to it, or if this would make it better for them, sometimes it might be just do it quickly and get it over with, but communicating with the patient and figuring out if that's the right approach. We can't just go in and go, we're just going to get this done. But if that's what works best for the patient, then also consider that to be an option as well.
Other questions, folks? Well, Nancy, I sure want to thank you for this topic. I think I mentioned when we first started connecting, we really have not had this topic within our series of 10 years of lectures or whatever. So and yet it's important. So it's been wonderful to bring your expertise into the room and get us to start sort of addressing trauma-informed care with a little bit more background to it. Everyone, thank you for attending. And I didn't know if you had something more you wanted to say, Nancy?
No, thank you for having
okay.
me. Like I said, my email is in the slide deck. So if you have specific questions, I will try to answer them or try to point you towards some resources. But Thank you for having me.
All right, thanks everyone, and I will see you next week for week 8 lecture. Have a really nice weekend. The sun seems to be coming out.